The main presentation today is Kian Raiszadeh. Kian is an orthopedic surgeon. He's the CEO at SpineZone, and he is reinventing the approach to back and neck pain. Dr. Kian left his lucrative career as a lead physician and orthopedic surgeon at Kaiser Permanente because he felt that he could have a bigger impact on bone and joint health if he started his own company. So that's the theme today, right? How do you redesign specialty care? So he helped develop a software solution to help manage chronic conditions, and then they signed up with some large groups. And in 2015, he joined forces with his brother, and then he went full-time. And now he is bringing it to the patients around the country. So welcome, Kian. Please unmute yourself and go ahead and start your presentation.
Great, thanks, Yuli, and great presentations today. I think so many people doing a lot of great work. So excited to be part of the presentation, and Yuli and I have been friends for many years as fellow Kaiser docs. It's been great to see how this has grown. So congrats to you, and what a great group of entrepreneurs and physician investors you've collected here. So I'm excited to share our journey in healthcare. My background, as Yuli said, is as an orthopedic surgeon, and I can share a little bit about my personal journey. From early days of playing competitive sports to semi-professional tennis, it was a very transactional and very linear and exciting life, and got to be an orthopedic surgeon and really had a unique crisis of sorts that occurred after being in a large health system, Kaiser, pretty much getting paid more than I deserved, and quickly feeling year over year how I was just a cog in a wheel. We had a unique perspective, and I'm sure many of the orthopedic surgeons on the call here today also see that the opportunity is so massive to add value earlier in the care pathway. And I felt I was in the end of the patient journey, and patients came to me assuming that I had all the answers. And, my real answer was the knife. And I quickly learned that there was a very small percentage of things in orthopedics with musculoskeletal health that we do very well. The vast majority of things don't need surgery. However, myself and my colleagues, we all understood, the rate of over-operating was so high. So I ended up being at this fork in the road in my life where it really didn't work out to continue at Kaiser, and was having to decide whether to go down this path. And really, it was one of the more challenging decisions I'd made, but I have never looked back, in the ability to now enter into this exponential world of being able to access so many more patients with our philosophy. So happy to share that with everyone today. The problem I think we've all identified here, coming at it at different angles, the way we see it is that currently its care is siloed throughout not just musculoskeletal care, but you have specialists in one area, you have doctors in another area, you have imaging centers. Everything is incredibly fragmented and siloed. So I think we all understand how fragmented our care has been across the country. Within musculoskeletal care, how we've approached it is to center it completely around the patient, and not necessarily have the focus of it needing to be technology-based or service-based, but actually understanding what the patient needs. Investing heavily in the technology to enhance that connection, but also creating an environment in which all of the services surround the patient. So whether they need the rehab, the injection, whether they need to see a surgeon, in the end of the day, we've created a software platform to guide the patients along the journey from beginning to end. And we realize we can cut the rate of surgery in half. 80% of patients are off opioids. After studying this in one of our large health system partners, as Yuli said, I left medicine back in 2015 to build the team, raise the money, and really create a robust platform around all of musculoskeletal health. And the paper that really outlines our philosophy, and which I think is so well outlined, is by Michael Porter, from the Harvard Business School, really identifying what it means to have an integrated practice unit. I think so much of the problem in healthcare right now is we're not differentiating what is a truly an acute system, acute issue versus an acute on chronic or a chronic issue. I think we do acute care fairly well in the US, but the chronic symptoms, when they manifest, they've been evolving over many years, and it takes a multidisciplinary team to address this. And so the point of care when a patient comes in for, whether it's belly ache, whether it's for musculoskeletal pain, whether it's for a headache, whether it's for their coronary artery disease, this has been a chronic condition developing over decades. So how we view that is very similar to how Michael Porter described that, as an integrated practice unit. All the practitioners and all the care surrounded around the patient well before any specialist is needed. So that's the full cycle of care, and we do it in a way where the patients want to engage. So if it's digital, we engage them digitally. If it's on-site, we engage them on-site as well. And so for us, the journey that we've created has been to universally do an online assessment. However, we've seen, and I think consistent with other health systems, that about the 80% of the cost is driven by 10, 15% of the population. Usually it's the population that doesn't consume a lot of the digital resources. So it's the 60-year-old debilitated patient who's deconditioned for many years, that has one surgery, then has another surgery, then is further debilitated. And it's that small cohort that is significantly driving the costs. The digital aspect's critical because we want to be preventative and getting to those patients early before they get further down the care pathway. Either way, we're able to access these patients for their musculoskeletal care in a very comprehensive fashion. On our on-site locations, we have medical grade equipment, using biofeedback, using objective measurements to make sure we understand the strength of each of the specific body muscle groups associated with each of the joints. We integrate all the software with the hardware, and we're able to go live in our VIP clinics within a matter of 3 months. And all of our contracts are really long-term, and that's been a key component, is that we don't really view this as a short-term interaction on a fee-for-service basis. So capitated long-term contracts over 3 to 5 years, such that we don't want to decrease surgery only for 3 months or 6 months. This is a radical new paradigm so that patients have access to this continual non-operative care to prevent them from needing that next level of care. By far the biggest driver of cost is surgery, and many times when it's done in a patient who's not optimized for surgeries, this can significantly create worse outcomes. So our philosophy is based on a lot of the literature that's been out there that we've seen around high intensity focused exercise. And we put it all under one umbrella and created all those specific modules for each of those musculoskeletal conditions. I think the one area that I would highlight is how important the behavioral health component is. And I think Ben mentioned it during his talk, and I think around the table, there's probably very little disagreement around how important this is. We have 60 to 70% of our patients having some degree of anxiety, depression, catastrophizing. Being able to treat that in a way that completely manages that within their rehab experience is very, very critical. So that is a key component, and along the lines of all the other components of musculoskeletal health, which are posture, it's really where we look at it as a biopsychosocial model. We know all these components are very significant, and without addressing that, we're not able to consistently make these patients better. So this is a look of some of the hardware that we use commercially available to objectively measure strength in different body parts, and to objectively then see over time how much their strength improves. This can be important for an 18-year-old athlete or a 90-year-old who's a fragile old patient as well. We've had the opportunity over time to now look at patients to see what is happening actually with their muscle physiology. So we've had the fortune of working with some of the best muscle physiologists in the world at UCSD that have understood how muscle changes from going from a normal appearance up here, where you can see this cross-sectional MRI of the muscles around the spine, and over time how that can atrophy and how that can, the fat can infiltrate. And once it gets to a point where the fat has then been converted to scar tissue, then the cat's out of the bag, meaning I could have a very debilitated condition, and if I have this fatty infiltration and I have a disc herniation, the reality is that I could have surgery to take the disc off of my nerve, but I don't have any other supporting structures that we see time and time again. When the muscle's weak, you get adjacent level disc disease, you get progression. So specifically in the spine, this is very important to understand where patients are in the spectrum and how much debilitation and atrophy they have. So when we looked at this with functional MRIs, we were able to show that for the cohort that improved versus did not improve, we look consistently, we're able to see the volume of the muscles, both the multifidus, specifically in the rector spinae, which are the supporting muscles of the spine, how they were consistently able to have increased muscle bulk and a decreased fatty infiltration or fatty fraction. And this was correlated with their functional outcomes. So the education that we give patients is very important from the beginning, in that many patients will be very debilitated when they start and they think they need a quick fix. And the mindset that we're giving them is that this is right now an acute presentation of a very, very debilitating problem that you may have, but it's been an evolution for years. And I think this is the new mindset that we need to have overall in our healthcare, is that even though we're presenting with what we think is a very severe problem, it's been an evolution for years. We can actually, unless we look at more of the core issues around that and we have a long-term view, having a very transactional view for health is going to be usually detrimental. So I have some case examples here that demonstrate really the core philosophies that we have and how we approach patient care. This is a patient who's a 64-year-old ophthalmologist, avid tennis player, comes in with pretty significant pain, did not get any imaging to start with, and really was able to, for the first couple weeks, do the rehab, then started having some issues over time. Within the integrated model that we have, the way the care coordination occurs is that within our model, we're able to have our medical professionals evaluate the patient throughout the process and get the MRIs and injections as needed. So we were able to get an MRI for this patient. We were able to see that he has very advanced disease. And for those clinicians on the call, you can see that this is a significant constriction of the spinal canal here and a slip vertebra. So presented with a classic, back, leg pain, was about 4 or 5 weeks into the rehab and essentially had a surgical consultation. And every one of those consultations said, there's no way this is going to get better conservatively. Had a significant behavioral health component. We were able to engage him for another 5 weeks, so a total of 10, 11 weeks of treatment. We were able to temper it with the behavioral health component that we utilize, use injections. And because of this integrated practice unit model, this patient got all the care he needed before he actually needed to have anything else done. So what we were able to show was that initially he had a certain level of strength in his back. Over time, after he completed the program, he was able to significantly improve his strength, strength being one component of what is prognostic for a good outcome. And so we're able to now take what was traditionally a patient who would have failed a couple weeks of therapy, gone to see a surgeon, had a 1 or 2 level back fusion, and then really enable him to get back to a fully functional life, back to playing tennis, totally empowering what we know is the potential of someone. What we consistently see, and this has been the exciting part as an orthopedic surgeon, is that so many patients have presented with complete disconnect between what we see on x-ray and how they're functioning. Sometimes we know patients have severe disease, they're functioning very well. Sometimes patients have no disease and they have very little, they have extremely poor function. So we're constantly impressing upon people the ability for our own bodies to heal. And we consistently see this time and time again. When we objectively address the core rehab principles on this biopsychosocial model, we're able to get these patients better. This is another case example of a 36-year-old female who was extremely debilitated by this very large disc herniation. You can see here, causing severe constriction, had debilitating buttock pain, was able to barely walk. Saw early on in the care process a couple surgeons, both of which who were saying need surgery. And you look at her MRI and you're like, yeah, this looks pretty bad. But she wanted to give it a shot at the non-operative pathway. Acute disc herniations are known to resorb over time, but this has been going on and progressively worsening over a 3-year period. So when we saw her, she had just lost her job. There was a significant behavioral health component. So she started engaging and had some spikes in her pain. And basically she was able to, within about 14, 15 visits, a couple injections, able to actually see significant relief, and able to then, because she was looking to get pregnant, had a follow-up MRI, which we almost never get because it's not really indicated, but she was looking to get pregnant. She wanted to make sure that that disc wasn't as significant before. And what we saw was pretty impressively that this was an example of really a star patient who did everything as she should, created an optimal environment for her body, both from a mindset perspective, from a behavioral health perspective, from a strengthening perspective. And we saw this disc herniation going away after 3 years. So it's exciting to be in a place where what we're doing is really opening up the opportunity for these patients to see how incredible our bodies are if we can give the right environment for them to heal. So what we're doing now is we've had the opportunity to work with major health systems and health plans. We have over 1 million lives under contract. We have collected all of these data points, and now we're using AI to more specifically target patients who we think are earlier risks of dropping off. So we're using those predictive analytics to really identify that 40-year-old patient who his pain, his functional outcomes, his strength isn't improving as we would anticipate, and he's at risk for dropping off, so we can intervene earlier. So that's how we're using that. And essentially in the end, what we consider to be, where we want to be and where we think healthcare should go. I think broadly throughout all of healthcare, there's so much, if you look at how we overutilize cardiovascular services, how we overutilize GI services, so much of the care is specialty driven. This, case example of an integration we did with one of the large health systems was able to show before we got into the health system, they had a surgical rate of about 6%. And I think across the country, when you look at patients going to a rehab center for non-operative care, the rate of surgery is about 6 to 8, 9%. And we were able to take that to below 1%. So it's been a really exciting journey to be able to partner with forward, viewing health systems and health plans that really see where musculoskeletal care should go. And I agree with the other comments that were made previously, which is this model really applies to all of healthcare in the US, which is so transactional and so downstream of where we should really intervene. Most of the intervention should be occurring at the PCP level. The PCP level is where we should have all of the chronic disease management programs, so that by the time we get to the specialists, it's truly indicated. And part of the problem in our healthcare system is that we're so overly specialty focused, and we have just too many surgeons and specialists. So our problems are many, but I think I'll stop here and take any questions.
Thank you.
Thank you, Kian. Yeah.